Welcome to another episode from the Veterinary Medicine Digest. Today we're diving into a fascinating area of veterinary surgery that's changing how we approach spinal stabilization in our canine companions. Spinal instability is a significant concern for dogs, often leading to neurological problems and pain due to a variety of conditions. When conservative treatments aren't enough, surgical stabilization of the spine becomes necessary, especially in cases with vertebral column instability, spinal cord compression, severe pain, or progressive neurological dysfunction. One of the most common surgical techniques involves using pins or screws in conjunction with polymethyl methacrylate, a type of bone cement. However, performing spinal stabilization is incredibly challenging due to the unique and complex anatomy of the vertebra and their close proximity to vital neurovascular structures, which unfortunately introduces the potential for serious and even life-threatening complications. In human spinal surgery, there's been substantial progress with intraoperative navigation techniques such as computer-assisted surgery and technologies based on computed tomography, like computer-assisted design and manufacturing. Specifically, three-dimensional printing, or 3D printing, plays a crucial role in the advanced technology for spinal surgery. It's a multi-step process where advanced diagnostic imaging, such as computed tomography scans from an individual patient, are used to create a patient-specific drill guide template. This template is then used during surgery to precisely place implants in predetermined areas. In human medicine, this computed tomography-based computer-assisted design and manufacturing technology for developing patient-specific drill guides has already demonstrated increased accuracy and safety during vertebral implant placement when compared to conventional freehand techniques. Reports have also emerged about the use of 3D printed guides in various applications for the canine spine, both in clinical settings and in cadaver studies, showing a very high degree of accuracy. Yet it's worth noting that many of these prior studies featured implant placement performed by only one or two surgeons who already had significant experience in spinal stabilization. This naturally raised a question. Would these advanced guides prove beneficial across a wider range of surgical experience? This study aimed to compare the placement of vertebral implants using these patient-specific drill guides versus the traditional freehand technique. They hypothesized that using CT-based patient-specific vertebral drill guides would lead to a higher proportion of acceptably placed implants in the canine cadaver spine, regardless of the surgeon's skill set. To go into what was found in the study, they evaluated a total of 477 3.2 millimeter cortical stainless steel pins that were placed across 240 vertebrae in 24 canine cadavers. This total included 239 pins placed in the 3D printed guide and 238 pins using the freehand technique. The procedure was carried out by 6 veterinarians whose experience levels range from 2 to 15 years in the field. The results are quite compelling. When assessing implant placement, a notable 152 out of the 339, or 63.6%, of the implants placed in the 3D printed guides were considered to have optimal placement. This is in stark contrast. Only 115 out of the 248, or 48.2%, of the implants placed using freehand technique achieved this optimal grade. Looking at overall acceptable placement, which includes pins that were optimally placed or had only partial penetration of the medial pedicle wall, the 3D printed group showed an impressive 87.5% acceptable rate, while the freehand only had a 69.8% acceptable rate. This difference was statistically significant, indicating that pin placement using 3D printed guides was more likely to result in acceptable placement compared to freehand technique for surgeons across all experience levels. The statistical analysis further underscores these findings. The freehand technique had significantly reduced odds of acceptable pin placement compared to the three-dimensional printed techniques. Interestingly, the specific vertebra also played a role. They observed that the T10 and T11 vertebra had lower odds of acceptable placement when compared to the L1 vertebra, which served as the reference point. Furthermore, when comparing the surgeons, one particular surgeon, which was surgeon 2 in the study, demonstrated greater odds of acceptable pin placement compared to surgeon 1, suggesting individual proficiency that could play a role, though there were no other statistically significant effects as far as the surgeons or interactions between the main variables. Moving into the discussion, the study clearly demonstrated that surgical technique significantly influenced the acceptable placement of pins in canine thoracolumbar spine. The use of 3D printed techniques consistently resulted in a higher proportion of safely placed pins, with 87.5% of the pins graded as acceptable for the 3D printed group compared to the 69.8% in the freehand group. Additionally, a higher percentage of pins placed in the 3D printed technique, specifically 64.6%, received the optimal placement grade compared to the 48.3% in the freehand technique. The acceptable placement percentage for the 3D printed group in the study aligns with previous reports. However, the percentage of pins classified as optimally placed at 64.4% was somewhat lower than what has previously been reported in other studies, which ranged from 79.3% to 100%. The inconsistency might be explained by differences in the methods. In the study, implants were left in the spine for post-operative CT and grading, which could lead to a beam hardening artifact and that might have overestimated possible canal breaches. Other studies, in contrast, either removed the implants before imaging or only created the drill tracks. Another contributing factor might be the study's design, which involved bilateral implant placement. While other studies also place implants bilaterally, some remove the first implant before placing the second one, or only assess the drill tracks, thereby decreasing the chance that the first implant obstructed the placement of the second one. In this study, if resistance was met during the placement of the second pin, the implant trajectory was slightly adjusted, which could have led to deviations from the pre-measured acceptable placement. There's also the study by Mullins and colleagues, which was published around the same time as this study, which found similar accuracy between the freehand probing technique and 3D printed drill guides. The difference in their findings compared to this study could be due to the specific freehand pedicle probing technique they employed, where a cortical defect was made at the entry point and the cancellous bone was then probed to determine a safe trajectory before drilling. It's possible that this probing technique improves the implant placement. Additionally, in that other study, they used a single highly experienced surgeon, which will likely influence the overall accuracy with the freehand technique. In this study, the surgeon who created the 3D printed drill guides, which was surgeon 2, which was the most accurate surgeon, was likely benefiting from their extensive experience with the cadaver work and their direct involvement with designing and manufacturing the guides. Beyond the technique itself, the specific vertebra also influenced the odds of successful pin placement. Both the T10 and the T11 vertebra presented lower odds of success compared to the L1 reference. This can be attributed to the anatomical characteristics of the mid to high thoracic vertebrae, such as the limited lamina, narrow bone corridors, steep corridor angles, and their closer proximity to the chest, which makes implant placement more challenging. The presence of the anticlinal vertebra at the T10 to T12 level also adds to the difficulty. Interesting, the guides for T10 were designed differently contoured to the cranial and proximal aspects of the spinous process, unlike the other guides that were contoured to the caudal and proximal aspects. They suspect that this design difference might have affected the surgeon's comfort level with placing the pins at T10. The findings of lower acceptable placement odds in T10 and T11 contrast with a study by Mariana and colleagues, which reported 100% accuracy in T8 to T13 vertebra. This difference is likely due to method variations. In the Mariana study, implants were placed bilaterally, but one at a time and then removed, which avoided beam hardening artifacts and the challenge of obstructing previous planned placement of implants. Also, Mariana study limited the surgeons to just one side based on their handedness, which might have influenced their results compared to this study that we're presenting here, where the surgeons placed implants on both sides. There are limitations to this study. A primary one was the use of a standard pin size for all cadavers. In a clinical setting, the surgeon selects the pin size based on the preoperative measurement of the pin and the pedicle thickness, and using a fixed size might have led to an overestimation of canal breaches if the pin was too large for that certain vertebra. The use of stainless steel pins also contributed to a substantial beam hardening artifact on the CT images, potentially overestimating canal breaches. Additionally, as a cadaver study, they could have assessed a potential compromise to vascular structures beneath the vertebral column during pin placement. A practical design flaw in the drill guide was that it didn't allow for the removal of the drill bit after making a pinhole, necessitating the guide's removal and replacement. While not an issue in a cadaver study, this could be problematic in a live clinical setting. Finally, the time required to create three-dimensional printed guides can range from 20 to 90 minutes, possibly longer, especially with a learning curve to take into account, and it might not be practical for an emergency situation, such as with a spinal fracture. So in conclusion, the findings of this study underscore that three-dimensional printed technique is an effective and superior alternative to conventional freehand vertebral pin placement in canine cadavers, at least. This holds true regardless of the surgeon's experience level, as evidenced by the high rate of pin placement acceptability. While further ex vivo and clinical studies are certainly warranted, this research provides valuable insight into advancing veterinary spinal surgery. From a personal note, I do have a lot of experience using 3D prints and 3D guides for the placement of pins in surgery for vertebral stabilization. So if anyone has specific questions on that or just general thoughts, please let me know. And we also have the ability to design the 3D prints and send them to people who are interested in using them. So please reach out in the comments if this is something that, again, you have questions or would want help with. Otherwise, thank you for listening to the Veterinary Medicine Digest. The title for the reference paper is below in the video description. And of course, remember to test your knowledge by answering the questions in the description below. And as always, keep your minds inspired, hearts light, and tails wagging.